a similar topic from his perspective.
Well, hello again, and I think we're going to be speaking a little bit about the clinical aspect. This is customized per speaker as well? No, okay. So we're going to be talking a little bit about the clinical aspect of the trans-PRK or the StreamLight vision and some of the things that we've learned in the last few weeks. I also thought that while I was trying to study a little for talking about transepithelial ablation, I did go back and revise a little bit about the epithelium and epithelial healing. So it's been a long time since I read about the epithelium, so I thought it might be nice to actually talk a little bit about what the epithelium is, a little bit more about what is important from the point of view of healing of the epithelium, because if you're going to be taking out the epithelium in different ways, it's also nice to know how this is going to affect the healing of the epithelium. So again, going back into textbooks, the important layers, and this is important here because all of us know that the epithelium is made up of three main types of cells. The important layers here are the basal epithelial cells that you see here and the basement membrane of the epithelium. And the reason this is important is because each of the techniques that we use to remove the epithelium is going to cleave the epithelium at a different place. And we'll come back to that in a short while. So, what happens when you actually take out the epithelium from the cornea? When you debride the epithelium from the cornea, that is, you denude the epithelium like you see in this is an intact epithelium. After you denude the epithelium, you have an epithelial defect that forms. So what happens after this? After this, the process of reepithelialization actually starts by some of the cells moving across and covering the epithelial defect in a single layer. It's not that the epithelium heals to form a complete stratified layer in one go. And this stratification is what takes time, and this is the reason why post-PRK or post-epithelial removal, you do have a lag phase before patient's vision gets much better, because you do have a lot of irregularities on the surface of the cornea. So when you actually look at this, what happens is the epithelium behaves in two ways. As soon as you have an epithelial defect, the cells of the epithelium in the area just next to the defect, they actually develop something called pseudopodia. And they lose their junctions, that is, they actually separate from the main bunch of cells, and a single layer of epithelial cells starts to crawl across the epithelial defect. And this is facilitated by the deposition of fibronectin and some other substances on the surface of the corneal stroma. Now this is important because what also happens at the end of the healing is once all the epithelium comes to the center and closes off, it doesn't stop there, it actually bunches up. And that is the reason why a lot of epithelial defects, once they heal, you see an elevated ridge of epithelium which will correspond to the cylindrical power and sometimes also myopia that you get post-PRK. Now these are some interesting confocal pictures. The one on the left side shows you what epithelium does. It actually is like a slide. A large portion of the epithelium separates and starts to move centrally to cover the defect. The picture on the right side actually shows the elongated pseudopodia of the epithelium as it moves across. I just thought that was interesting. So how long does epithelium take to heal? On an average, if you have an epithelial defect that is approximately 5.5 millimeters in diameter, it takes around 36 hours, that is a day and a half to heal. If you have a larger epithelial defect, obviously it's going to take much longer. So let's see how that actually changes with time. You also have numerous healing patterns of epithelial defects, which will again be interesting to see when you're doing PRKs. Most epithelium tends to heal and seal off in the center. And that is the reason why once the epithelium closes down, most patients complain of poor visual acuity on the third or the fourth day, because that's when the ridge happens in the center of the cornea. So what impedes or what impacts healing? Obviously, if you have a healthy stem cell niche, we're going to have epithelium healing very quickly. But what is also important is the fact that you need to have good nerve supply to the epithelial cells. Substance P and a lot of other substances have been shown to impact the speed of healing of the epithelium. And if we do not have good nerve supply to the epithelial cells, healing is going to be impeded. The other important thing about having good healing of the epithelium is to ensure that there is no inflammation on the surface. And this is another reason why recently, earlier we used to use topical NSAIDs after PRK to reduce pain, but now we've started using topical steroids rather than NSAIDs because it doesn't seem that topical steroids increase the risk of infection after PRK. And that's a typical ridge that I was talking about after healing in PRK. So, what are the different ways in which you can remove epithelium? I'm just going to run through some of these. Classically, you also had loose epithelium that is removed by a brush. You can remove epithelium using an Amoy's brush. Some people actually are using it. Very elegant method of removing epithelium. Other epithelium that is actually much harder to remove, like post-PRK, you can use a diamond burr to remove the epithelium, or you use a classical technique where you use a Kimura spatula and scrape off the epithelium. Well, either way that you remove the epithelium, remember that you're leaving the Bowman's layer intact. You're removing the epithelium at the level of the basement membrane. That is, removing the epithelium as well as the basement membrane. And this is important because the second method of removing epithelium, that is the Epi LASEK, very interestingly does not cleave through the basement membrane. It actually cleaves through different parts of the basement membrane and the Bowman's membrane. Thus, though after the Epi LASEK is done, you will tend to see that the cornea is very smooth. But if you look at electron microscopy, you see that the cut is not as smooth as you would expect it to be, and it tends to be a little irregular on the surface. Obviously, Epi LASEK is not very popular right now because of the fact that it adds another extra step, extra time, and also extra cost to the procedure of doing epithelial removal. LASEK obviously came into the market because it sounds just like LASIK, but then the fact that you use alcohol to loosen the epithelium also seems to give very good outcomes. Now, personally, I don't use LASEK. I actually tend to just mechanically debride the epithelium because of one interesting experience I had one day. So I was operating as usual, and I used to use alcohol to debride the epithelium. I asked my nurse at the end of surgery to give me saline to flush the cornea, and she handed me a syringe with alcohol, and I flushed the patient's eye with alcohol and caused a huge epithelial defect on the whole of the conjunctiva and the cornea. So since then, I just use paracaine to debride the epithelium. Does not look very nice, but then actually is as effective as when you use alcohol. Now, why is all of this important? What is important to note is the fact that PRK, Epi LASIK, and LASEK have the same outcome from the point of view of vision, which is what is important. There is no difference in the accuracy of correction as well in all of these three methods. So, now there are a couple of articles that I'd like you to look at, and one of these is a comparison of three epithelial removal techniques: trans PRK, that is using the laser, mechanical debridement, and alcohol assisted. And if you look at the safety of all of these at the end of 1 year is exactly the same. All of these methods seem to have the same kind of safety index from the point of removal of the epithelium. Now, between mechanical removal and alcohol-assisted removal of the epithelium, what is better? And this is an important article from only one point of view. This is a confocal study where they removed epithelium using mechanical debridement, and they found that the keratocytes after removal actually disappeared to a large extent. The alcohol-assisted debridement caused reduction in the number of keratocytes, but not to the extent of the mechanical debridement. Now, why is this important? This is important because of another article, which is one of my all-time favorite articles in understanding corneal wound healing after refractive surgery. If you get your hands on this, please read this. This is a very interesting article that talks about how the cornea behaves once you remove the epithelium. The cornea does not know that you are trying to do surgery for a patient and you are doing good for the patient. All it knows is there's an injury to the surface of the eye. And so the cornea is tuned to behave in such a way to protect itself. So when you remove epithelium on the surface, because of our evolution, the cornea believes that there is a probable viral attack that is going to go on. And so it actually starts to kill off the surrounding cells below the epithelium by a process of apoptosis. And this is protective because typically virus spreads from cell to cell. So it's like you have seen forest fires, right? How do you stop a forest fire? You actually create a zone of clearing. This is exactly what the cornea has learned over several years, and it kills off all the cells in the surrounding areas once you have an epithelial defect. And this was a protective mechanism that was developed. Now, when you scrape off the epithelium, like in PRK, this is staining for cells that are apoptotic. This is PRK on the surface. This is LASIK at the interface. You have some amount of apoptosis in LASIK as well, but not as much as in PRK. And the source of this signal that causes the apoptosis is the cytokines that is released from the epithelium. So, if you debride the epithelium, like you saw in the previous paper, and you leave it live for a longer time, it is plausible that you expose the corneal stroma to cytokines for a longer time and risk higher amount of apoptosis and consequently a greater wound healing reaction, potentially more haze in the future as well. And that is what that paper was getting at. And that's the reason why it's important to understand how different techniques of removal of the epithelium can affect the results of your surgery as well. And this is what you will see if you see that you have a lot of wound healing reaction because of the apoptosis on the cornea. Well, the other reason why epithelium is really important is because epithelium tends to smoothen out irregularities on the cornea as well. So if you have a stromal irregularity that you see here, this is the post-PRK haze that patient developed. You see that the surface actually is really nice because it's really nice and smooth. And that is a very important role of the epithelium because it helps you in doing PTK to normalize the shape of the cornea. So one problem that we used to have, and this is a video from the earlier days when we used to do PTK with PRK. So if you observe the PTK that actually is being done here using the EX500, you'll see that the ablation is more in the periphery than in the center, and at the end of the ablation, you'll actually see a gutter that forms in the periphery, and most of you would have seen this when you're doing your PTK. This I recently learned is because the pattern of ablation is not optimized for removing the epithelium uniformly, and there is more removal in the periphery as compared to the center, leading to a peripheral hyperopic ablation and a myopic shift for your patients. Now what this also translates into post-op is in patients who have this kind of ablation. This is a post-graft patient, but also this patient has developed significant amount of corneal haze in the periphery where you have this gutter. And retrospectively, I realized that this happens because after you do PRK, you apply mitomycin C on the cornea. But where do you put mitomycin C? On the center, not in the periphery. And this is the reason why some patients actually have increased scarring in the periphery. If you have increased scarring, you have more flattening there, and you have more steepening in the cornea, exacerbating the amount of myopic shift in these patients. So refractively not predictable. So trans-epi PRK, like you just heard right now, is supposed to be optimized epithelial removal. The advantage I could think of is the fact that you don't have a lag time between the two procedures. You don't have to finish one, then go back and do the second one. The removal, the diameter of epithelial removal is not an issue. As you've seen with the EX machine, if you try to remove epithelium in a 7.5 optic zone with a 9 millimeter total removal, it allows you to ablate only 50 microns. And you'll have to do 2 or 3 ablations to ensure that you get all the epithelium off. With trans-PRK, there doesn't seem to be an issue, and also seems that there is going to be less myopic shift in these patients. So we actually did a small study with StreamLight or trans-PRK in the last month, where since we do a lot of PRK, we included 38 eyes of 19 patients. All of these patients were patients who were suitable for PRK, and we randomized these patients into one eye for trans-PRK or StreamLight and one eye for regular PRK with manual debridement. The manual debridement, I think I'm going to take a couple of minutes more. Manual debridement patients, we removed the epithelium in an 8 millimeter zone, and then the trans-epi PRK was done in only patients who had some cylindrical error as well, because that limits the epithelial removal to 8 millimeters, and we used only a wavefront optimized treatment. We had follow-ups at 1, 2, 3, 4, 7, and 30 days, and then slit lamp photographs at every visit, measuring the size of the epithelial defect. We had an ocular pain score, and we have 12 patients who've completed 1 month follow-up and 7 patients who've completed 1 week of follow-up. So, this is the preoperative characteristics of these patients. The average myopic refractive error between the two eyes is about the same, and the range of correction is about the same in both these groups of patients as well. So what factors do we expect to be different if we are doing a different method of epithelial removal? You think that maybe the speed of healing is going to be different. You would expect that maybe the pain is going to be a little different. Maybe the visual outcomes may be different. Maybe the quality, and maybe even haze. So we can look only at the first 3 now because we're still in the first month after follow-up. When you looked at epithelial healing, it seemed that the healing pattern was slightly different, but the speed of healing in these two patients, or at least these two groups of eyes, was exactly the same. And it seemed as if by day 4, all epithelial defects had completely healed. So there was no faster healing by one procedure or the other. Now, what about visual acuity? Visual acuity also at all time points, day 1, day 3, day 7, and day 30 is exactly the same in both eyes of the patients. So the StreamLight is exactly the same as you would get with regular wavefront optimized PRK. What about pain? Now remember, these patients were masked. They were not told what surgery they're having on either eye. And just to make sure that it appeared the same, we just wiped the eye that were having the trans PRK to make sure that it appeared the same. And the pain scores were exactly the same as well on all of these days for these patients as well. So, what's the big deal? How is trans PRK better than wavefront optimized PRK? Well, from my point of view, because epithelial healing time, pain scores, and vision are all the same, this does not mean that there is no big deal here. The actual big deal is the fact that it is the same. Because I think from the point of view of a surgeon, this probably is a better procedure because you actually are more in control when you're removing the epithelium. And from the point of view of patient perception, it probably is a better procedure because the patient perceives that you're doing a transepithelial procedure without touching the eye, without using an additional instrument. It's good that the refractive results and all of these are the same, at least they're not inferior to what was already existing, because that was one of my fears when I was fearing refractive overcorrections in these patients. So, we still have to worry about two of the major issues with PRK, that is discomfort and time to recovery. They're still about the same. We've solved the haze issue with the mitomycin C. But then in the future, I think we could look forward to a few more things from StreamLight. This is a post-DALK patient who we did a Contura treatment for. This was done just yesterday. And typically now StreamLight is available only for wavefront optimized treatments. We would love to have StreamLight along with Contura because that is the ideal kind of cases that you would like to do StreamLight with because you have the uniform epithelial removal. And in the future, we also would like to see StreamLight linked up to an OCT that measures the epithelial thickness so you can customize along with the many other things the removal of the epithelium as well. Thank you very much.